Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. Our mission is to provide hope for all of those suffering from pancreas disease through funding cutting-edge research, providing support and education, and advocating for better services and access to care. Some of the impact of the National Pancreas Foundation is awarding over 5 million grants to up-and-coming researchers to keep them in the pancreas field and moving care and treatment forward. We've endorsed over 180 centers of excellence across the country, from cancer, pancreatitis, and pediatric, recognizing that there are needs for all of our patients and, again, elevating the highest level of care. We also provide a variety of programs to volunteers, care providers, and medical professionals as well. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. Now I would like to introduce our next speaker.
Dr. Yazici is a physician scientist gastroenterologist with a focus in pancreatic diseases and health inequities. His research focuses on understanding contribution of diet, gut, microbiome, and microbiometabolics in acute pancreatitis in the context of healthcare inequities. He co-leads the Chicago Clinical Center for Multi-Institutional Type 1 Diabetes and Acute Pancreatitis Consortium. African Americans and Hispanics form the majority of his patient population at the University of Illinois, Chicago, and he takes care of patients living in the underserved neighborhoods of Chicago. These facts led him to further focus on health inequities and pancreatic diseases. He co-chairs the Recruitment and Retention Committee for T1DAPC, works closely with nonprofit organizations such as the National Pancreas Foundation, and serves as a co-chair for the NPF's AAI, along with Dr. Conwell. The multidisciplinary research team that Dr. Yazici leads at UIC contributed to development of the most diverse acute pancreatitis cohort in the U.S. More than 90% of patients he enrolls into pancreatic disease studies at UIC are minorities and exemplifies the service his team provides to underrepresented communities.
Thank you, Jenny, for that warm introduction. Before we begin, I want to start with a brief refresher on what social determinants of health are. These are the conditions in which people are born, live, work, and age, such as access to healthcare, education, income, housing, and social support. Social determinants of health play a large role in health outcomes and can affect individuals living with pancreatitis or pancreatic cancer. Unfortunately, these impacts are often felt more strongly in the Black community, contributing to disparities in diagnosis, treatment, and outcomes. We will include links to past educational videos in the description of this webinar for anyone who would like to explore this topic further. To get us started, it's my pleasure to introduce our first speaker, Tanya Louis. Tanya Louis is a nurse practitioner and nurse navigator at Northwell Health Cancer Institute. Deriving from her own breast cancer experience, she is recognized for helping patients navigate their cancer journeys. with a clinical focus on pancreatic and liver cancers. Tanya delivers compassionate, individualized care, combining her unique perspective, both as a patient and also as a clinician across Northwell facilities in Freeport, New York, and beyond. Tanya, thank you for being with us on this webinar and talking about this important topic. Let's start off with by defining what a nurse navigator is and describing how you support patients as they move through the healthcare system after they receive their diagnosis.
Sure. Thank you for having me here. So once the patient is given a diagnosis of cancer, as you know, that's a scary word for everyone. So I help the patients get through or scheduling their appointments, getting them connected with the right provider. Oftentimes, patients are given the diagnosis maybe starting in the ED, where they go in for, let's say, abdominal pain. The first scan that's being done is in the ED, and maybe incidentally is where a lesion is found or a suspicious lesion. So I am able to connect with the patients and kind of guide them on the next steps in terms of getting them connected to the first and appropriate provider. I definitely start that discussion in terms of what we have, what opportunities and what programs we have, as well as what resources. So I'm essentially kind of taking them by the hand and say, okay, I'm going to connect you with your first appointment. There's a lot of discussion that comes out in that first initial call. The patients are anxious, nervous, not knowing where to begin. But just starting out with that first appointment with that provider helps them in the initial kind of call. And then from there, their treatment plan is then tailored to, after the first discussion or the first office visit.
I see. And that's in general the description of the nurse navigator, right? I mean, that's like their, by description, their main role is to help patients navigate through the system.
The nurse navigator is the first point of contact for the patients. We help them set up their initial appointments. We then connect with them after their visit in terms of carrying out the plan and discussion for the patient. So if there's any appointments that's needed or any clarification, just helping them through the journey is kind of where it starts with the navigator. The navigator is someone that's at the start of the diagnosis all the way to the whole journey of cancer journey, rather.
Okay. And how do you help patients understand the different members of their care team? Because it involves like multidisciplinary team, surgical oncologist, medical oncologist, radiation oncologist. Sometimes it becomes very overwhelming to patients at the beginning. And what type of unique strategies you have to help patients navigate that?
Yes, absolutely. It's first getting them to understand the disease process. That's something that the provider will then kind of start that discussion. And in the treatment plan, it's outlined, okay, you're going to see a surgeon. If it's for appropriate patients, they're going to see a radiation oncologist, a medical oncologist. So our role as a navigator is defining each provider and what their role is going to be in taking care of them and helping them in their treatment process on the cancer journey.
All right, Tanya, another question for you is about how the nurse navigators can help patients effectively, clarify and organize their goals and thoughts and know the questions that they need to ask.
Mm-hmm. Yes. So as a nurse navigator, our goal and our focus, during each call is meeting the patient's expectations, what their goals are, meeting short-term goals as well as long-term goals. So we want to start short or very small in the beginning. What would you like to happen in the next month or so? When patients then answer that question, we then are able to help guide them onto, okay, this is the questions that you need to ask your provider once you see them in order for you to get to that goal. The goal that the patient set at 1 month may not be the same goal that they're setting at 6 months, because now, the treatment has begun, the treatment plan has already started. So maybe as they're going through the treatment plan, they may feel differently. They may say, oh, I want to tailor this a little bit. So depending on the patient's feeling, what they would like to do, such as when we talked about getting to know the patient, right? So like they may have a wedding that they want to look forward to in the next 6 months or so. That may be important for them. So it's, so knowing that, it's like, okay, well, this is what you need to relate to your provider, that, you want to be there for the wedding that's, maybe your daughter, your son's wedding in 6 months. And then helping them develop those questions, because they may not know what questions to ask. Oftentimes patients sit there and they receive all the information, and some of it they retain, and some things they forget. And also connecting with them after their appointments. Okay, what was your understanding of that appointment? What did you hear? Because it's interesting to get the patient's understanding of what they heard and what was actually said in the visit. It's a good clue on, like, if they need more information, if they need more phone calls, checking calls. But I think just helping them develop questions that they can actually, each provider definitely put things in perspective for them. And then knowing that the different questions they're asking for different providers. And then at the same time, they can understand, okay, what that provider's role is in their treatment plan.
And so you also work in an area which also have a diverse patient population. So from great. Your own experience, what systemic challenges do minority patients face when navigating the healthcare system for a pancreas disease diagnosis or treatment?
Yeah, it's a nurse navigation is also a unique role in sense of getting to know the patient, not only their disease process or their new diagnosis, but it's getting to know their living situation, who their support systems are, what resources do they have nearby, geographically, where do they live? Do they have the capability of, when we tell them to exercise daily or to go out and get fresh air, it's really understanding where they live, if they have that ability to go out to take daily walks. So that's something that is, I think it's a unique thing that we need to have as part of the discussion, and really just understanding their the household dynamics, who they rely on as their support system. What does cancer mean to them as an individual? Because I know for what I find in the African American community, cancer is not something that's talked about in the home. So that's something that is getting them to share or open up, if they want to open up to their family members, and understanding what impact that has on their recovery process. Because I find that patients want to go through it by themselves, but having them understand that they can't go through it by themselves. They need to be able to get to their appointments. Who's going to take them to their appointments? Knowing that they may not feel that well after their appointments. So they may not be able to get in the car and drive themselves home. Some of them don't have a car. So it's really just taking the time out and understanding, what are some of the barriers, and just tailor those things to the patient's individual needs. It's really, I say that navigation is really, you're an extension of the patient now, and how, you need to kind of now make yourself, a valuable tool for the patient, and have them,
Definitely, this is a very important role, especially in patients who are requiring long-term care for cancer treatment, because it just doesn't end in a single visit. And I think it ties really nicely to the next question, which is the continuity of care for patients, because the transportation challenges, insurance coverage issues, language barriers for some of the minority communities, they may all have an impact on the continuity of the care that they receive. And you briefly touch on that. Is there any specific barrier that you acknowledge in minority communities?
Yeah. The first one that comes to mind and that really poses a challenge is their insurance, right? Some patients, they may not be employed, they don't have a job, they don't have insurance, or if they just started a new job, their insurance coverage doesn't kick in into X amount of months, or, depending on where they're at in their job process. And Patients oftentimes, I often hear them say, "Oh, I have to go to work. I can't make this appointment." So it's getting them to understand, yes, it's you're the driver of your care, but understanding that, if your health is not in the great shape, you won't be able to get to work. So I think sometimes for them, for patients who struggle with that, having insurance be a problem, or they have to go to work to make ends meet. So I do see that as quite of a challenge. And as soon as I identify that, I immediately try to get them connected with social work to see what resources are available to them, what financial support we can kind of offer them, that is out there. Because I think there are resources, but it's just getting them connected as soon as possible
I
to
see.
help.
Great. And can you little bit describe to us what your early interactions with patients typically look? For example, the initial check-in calls, frequency of communications, and the most importantly, like how do you really establish and build rapport with these patients?
Yeah. Definitely that first phone call is a bit of a challenge, because I always say like communication, it's body language, it's more than what the patient is verbalizing, but it's, knowing how much information is the patient ready to receive. So that first initial call can be a little challenging. I try to use certain questions to elicit some of the barriers that I think they might be facing. I kind of tailor my questions a little different to every patient, if that makes sense. Because based on how they're answering the question, it leads me to then go into the next question. Yeah. So I say that, each call is very different. For certain patients, and I always, kind of sense if they're ready to hear it. But I think that when I share my story, or I give them a brief overview that you're not alone. I understand how you feel. If they say certain things about, they may be hesitant to schedule their appointments. And I can, say, I understand how you feel. If you wouldn't mind, I would like to share my story. I felt the same way you felt. So I think just incorporating that for some patients definitely helped them to open up and be more comfortable to tell me, and kind of relax them a little bit, because I feel like some patients, when you are diagnosed with cancer, you feel like you're on the island by your own. And I always tell patients, you're not on this island by your own. That you have a support. These are the resources. These are a group of people that you need to take care of you. So I think that, the first 15 minutes is really just getting to know you, kind of getting to know the patients. So I call that getting to know you phase for like the first 10 minutes. And then, I just go off of I meet the patients where they're at, if they're ready, to talk about certain things. And of course, at the initial visit, when they come in to see the doctor, then, let's follow up with, okay, I'm the one that spoke to you over the phone. Nice to see you in person. So I feel that, that rapport starts on the phone call for a little bit, and then kind of tie it all in once I meet the patient in person.
I see. And I think that really ties well into the next question I think that I have in regards to cultural competency. I think you kind of already described how important it is for patients to understand that they are heard, and on the other side of the phone there is someone who can really listen and understand and try to address their concerns. So do you have like a case story, a success story, or an example where you think that a cultural component navigation made a meaningful difference?
Yeah. Yes. The one story that comes to mind is a gentleman that, the same age as me. He was diagnosed with pancreas cancer. He received upfront systemic therapy. He then went on to get surgical resection, and then had a few hiccups along the way in terms of the post-op recovery, minor things, kind of, feeling a little nauseous, not feeling 100% post-op. And, I think for him, he felt like he was young, right? That he can bounce back from surgery very quickly. And I think for him, that was a shock that, I'm young, I should be able to move around as easily as possible. Now I'm home recovering. But he struggled a little bit, expected, normal post-op complications such as, eating small frequent meals, feeling fuller quicker, feel like he's always tired. So I was able to add some support in terms of letting him know, yeah, I understand having that draining, that post-op drain, that JP drain, that could be cumbersome, because it's a constant reminder that this drain is in and that I'm sick. And I told him that I remember having that drain and feeling the same way. So I think because I touched upon how he was feeling, because I recognized it, because that's how I was feeling. So that, that made him kind of take a step back and said, okay, well, this is a normal feeling. And I only feel this way because I have the draining, but that's going to be removed. Once it's removed, it's kind of like, out of sight, out of mind. Like I feel well, and I said, you are going to get there. So I think just kind of giving him that encouragement, and then him seeing me that, wow, like you had breast cancer. You don't look like you had cancer. You look so well. So it's like, I think it kind of just puts certain things in perspective for him. Yeah.
Yeah, a real example of it. I think also, it helps patients to understand really these are some of the challenges that can be overcome. Looks like you being there, just living an example of it probably help him a lot, I think, to go through that stage. And in your opinion, how do you think that GI specialists and patient navigators and social workers, they can work together more effectively to address these challenges?
I always say, having that open line of communication, not only do we work within our department, but we also work with other disciplines outside the department. So it's so important to maintain that professional development, that professional interaction, and being able to put a name to the face. I think that collaboration, because then it gives patient a sense of, oh, not only does my doctor here knows all about me, but then they're talking on my behalf to another office, which I feel like it makes patients feel good, because it makes them feel like, as a whole, the institution, Northwell, cares about their well-being. And I think that as a navigator, we're the person to put those, kind of like the middle person, to then be able to kind of have the patients connected with other disciplines and being able to tie that all together. Because I think as a larger institution, it's hard to make patients feel that, right? So it's like, even though we're a large institution, but we have to make the patients feel like it's a smaller network. And I think that as a navigator, we're the bridge to kind of help them, feel like they're being supported through various disciplines. And I think, connecting with them and making sure that their services are being met or this is happening makes patients feel well. And I think that it's so important for us to maintain that professional relationship with other disciplines.
Awesome.
Yeah.
Great. And finally, in your own experience with the cancer, what changes would you like to see in the healthcare system to better support Black and other minority patients?
Yeah, definitely having patients, giving them an option, multiple options. I think that, we sometimes, as providers, there's zero in on one particular area, where I think that having patients know what's available to them, because they don't know where to start. They may be the first person in their family that's diagnosed with cancer. But I think what's important is to give the patients different options and give them all the possible tools and resources they need to then leave that appointment and go and do their own research. But I think that that's something, because patient, certain, we may not have access to computers or to like outside resources. So there, I think that just being able to present it to the patient and then have them, do their own research thereafter if they have any questions. But I think that, definitely have that variety of treatment plan presented to the patient is important. I think as a provider, that's something that we should be able to do and give them. So I think sometimes it's one particular option that's given to them, not knowing that they can have several different options to tailor to their needs. Yeah. Mhm.
Awesome. Thank you so much, Tanya. It was great having you on this
Yes, thank you for having
webinar
me.
today, and we really appreciate your time and support for our patients there. Our next speaker will be Namele Meza. Namele is a licensed marriage and family therapist and adjunct professor. She's passionate about enriching and supporting people in our communities so they may live healthier and fuller lives. For the past 10 years, Namele has brought that passion to a variety of clinical settings and currently has the honor of working with cancer patients at Facey Providence Hospital. Thank you for being here today with us, Namele. To start, can you share a bit about your role as a therapist and what supporting pancreatic cancer patients really look like in your day-to-day work?
Yeah, and let me say I'm really grateful to be here. I'm really excited to be here and share. I can definitely share about my role. So, first of all, I see only cancer patients, and I see patients who have been diagnosed with all types of cancer, including pancreatic cancer. So just people have that context. Part of my job is supporting those patients through any emotional, psychological, or practical challenges through all parts of staging of cancer. So from maybe some symptoms that they're unsure, to diagnosis of cancer, to treatment, possible remission, survivorship, and for some people, end of life. And so that spans a lot of different stages. I support people on the day-to-day with that emotional support. So often I hear patients talk about how they experience a lot of anger or fear, grief, sadness. There's a lot of emotions, obviously, that come up with this diagnosis. And oftentimes I hear them telling me that they want to be strong for their family members. So they try to protect them, their kids, their partners from really knowing the depth of their emotional experience. I often hear too from patients that when they do share, sometimes people's responses aren't very helpful. Sometimes they try to give platitudes or just they want them to be okay, and they find it helpful to have a space where they can really be honest about what they're feeling and have someone allow them to have those feelings, and they don't have to protect me from those emotions. Another part that I do with people on a day-to-day basis is building upon or creating healthy coping skills, working through identity issues and body image. Treatment can have, as you all know, a big toll on the body. So there might be scars, there might be weight changes, hair changes, some of them temporary, some of them more long-term. So really helping people work on their self-esteem, self-image, and their confidence again, because people often tell me, I look in the mirror and I don't even recognize myself anymore, and that takes a toll psychologically. I also support patients with navigating a lot of ambiguous treatment decisions, their practical concerns. A lot of existential questions come up about the meaning of life and why all of the pain and suffering that's come their way through this. So there's a lot that goes in, and I'm sure I missed something, but but that's the gist.
I see. Yeah, it looks like it really involves a lot of direct talk and communication and sharing with patients. And I think that segues into my next question about building trust with patients, especially those that come from minority communities that have, faced medical bias or discrimination. So Is there anything specific about how you approach to these patients to build that trust?
Yes, of course. I feel like the onus is on the therapist and the clinician to open that door for people to know that it's safe to talk about. There's a lot of ways that I do that. One is I ask, what messages did they receive growing up in their families or in their culture about therapy? Because they might come in with a lot of stigma. And I think acknowledging their efforts of, coming in, being courageous enough to try something new or something that's been looked down upon is a helpful conversation to have. I also acknowledge with them in our initial assessment that people have a lot of different thoughts and feelings about the medical system based upon their individual experiences and historical experiences. And I ask them, with that context, what are their thoughts and feelings about it? And people have a lot. They have a lot. And even if someone at that initial time may not feel comfortable because they still don't know me, at least I've opened the door so that they know it's something that I'm interested in, willing to talk about. Maybe once that trust is built a little bit more down the road. In addition to that, I just bring the basic building blocks of trust into my work. Brene Brown, the queen, has a great video called The Anatomy of Trust. I highly recommend it to everybody. But she talks about how to build trust, and I really do try to bring that into the work that I do. So having healthy boundaries in therapy, being reliable for them. If I say I'm going to do something, like, oh, I'll send you that resource, I'm going to do it, I'm going to follow through. Being accountable. If I say something that they feel is hurtful to them, either their cultural background or just not understanding them, they can bring that up to me. My ego is not important in that space. So I let them know that. Non-judgment, confidentiality. So all of those ingredients to make sure that they know they're in a safe space and there's someone who is going to validate them, especially when they do share with me those experiences that they've had. I think oftentimes what people tell me is they've been invalidated, they've been minimized, and I believe them. No, I believe that prejudice is real. I believe that discrimination happens, and I will believe their stories.
You briefly touch on the importance of being really able to understand and hear their thoughts. So I think that aligns and indicates the importance of this culturally relevant and also affirming approaches. Is there anything specific among these approaches that you use in this particular, underserved communities or minority populations?
I do. Like many therapists, I am eclectic where I bring in different theories and different tools that I've learned along the way. I am more forward-leaning with ACT, acceptance and commitment therapy. What I like about that is that it's very values-based and it's very individual to people. So I have my patients complete, together we do a values exercise, and they can identify what is their core, and that helps me build around that. And I think really support them in what is important to them instead of me telling them what should be important. In addition to that, there's a lot of different things I try to do. So one is language as well. I think that can be important. Because I speak Spanish, if I have patients who are monolingual Spanish speakers or prefer to speak in Spanish because they feel like they can express themselves better, then I provide therapy in that language. I think language has a big part to do with it. So if I don't speak the language that someone natively speaks, I do let them know that is important. If they feel like maybe I'm missing some of the undertones of things, then I can support them in finding a therapist as well who might be able to connect in that way. I think that that's a powerful thing. I also bring up a lot of questions about what is their cultural background, belief around cancer, around illness, healing. People tell me a lot about like that there's spiritual interpretations of cancer. I've heard about fate, karma. So there's a lot that comes into it. And also just how families or their community comes around them, or people who are sick. That helps me understand as well what that might look like for them and if maybe they need more support.
Awesome. And Namele, we also often forget that stress and trauma can be tied to a broader social or environmental inequities.
Yeah.
So how do you see that showing up in GI and pancreatic health in particular?
Yes, they are very real impacts on us. I believe that probably people are aware of those social determinants of health, but just in case, like, you know, food security, neighborhood safety, transportation, things like that, discrimination. So what research has shown and what we do know is that all of those social determinants of health significantly impact our bodies and how they respond. Again, there's been a lot of research on chronic stress, and those things are chronic stressors. They increase inflammation in our body and our ability to fight disease. So what I have seen is that sometimes there might be difficulties with, for example, medication adherence. If you only have a certain amount of money to go to certain things, like your basic needs, you might not get your prescription, especially if that's really expensive. So there might be some difficulties there. And people might see that as like, oh, they're not doing what they're supposed to do, versus really deep diving at what are the circumstances around this and how can we support the person. So there might be more hospitalizations if there's more complications or more flare-ups. That's possible as well. Obviously, I'm not a doctor and I don't know all of the inner workings of the body and everything. I'm very mindful of my scope of practice, but I do like to provide resources to people. Obviously, with the time that we have, I can't get into all of the things, but if it's something of interest for people, I highly recommend looking into the ACEs study. That's an acronym, ACES. It was a study done by the CDC and Kaiser Permanente about how these factors and these experiences impact our later health. I believe her name is Nadine Burke. She wrote a book called The Deepest Well, and there's great information there. And Gabor Mate wrote the book When the Body Says No. So if people are interested in kind of that mind-body connection, I feel like those are good, easy places to start and learn a bit about that.
Yes. And in regards to emotional and psychological challenges that cancer patients often experience, how do you help them navigate those feelings?
Yeah. Similar to what I said in the beginning, those emotions are pretty common. Diagnostically, that might look like anxiety or depression as diagnosis that I might provide if their symptoms align with that. But those are the two most common that I see. My work is trying to help people not get rid of their emotions, but to have a different relationship with them. So often I have patients come in and they tell me their goal for therapy is to not feel the feelings, to just be at peace and just, be all okay with what's happening. And if I knew how to do that, I think I'd be a billionaire by now, doctor. And I tell them, I can't take away those emotions. And part of trying to do that, the suppression of it, the trying to pretend it's not there, makes it worse. And so one activity that I do, for example, or one exercise is personifying anxiety and depression and having patients write to anxiety, dear depression. And then they have anxiety and depression right back. And you would be surprised how much of a relationship they have with these parts of themselves that they don't even realize. So just bringing awareness to that. And of course, there's a lot of other things that I do with people, but again, shifting what those emotions are, how they come up for them versus trying to suppress them. And on a psychological basis, it's a lot of identity work. And what I hear most often from patients is, I'm not the same person I was before cancer. And there's a lot of grief in that. And letting people have that grief process, in addition to figuring out for them who they are after cancer, especially after something that they didn't choose, they didn't want. And so really coming to acceptance with that and not looking forward, but learning how to move forward with that.
And in regards to the rest of the care team, to ensure that patients receive holistic and this culturally sensitive support from the team members, how do you work with them to make sure that, you know, patients go and, you know, participate, whatever that is really relevant to their needs, whether it's faith communities or other type of support systems?
Yes, 100%. I think that is very important because I'm only one person and I'm addressing a specific thing. So I definitely want to share with them that there's a lot of resources and a lot of people who are able to help with these different aspects of their experience. So for example, with, as you know, cancer patients experience a lot of pain. So I let them know we have pain specialists you can consult with. You can get information about maybe anything that they can prescribe or other ways that they know how to manage pain. If people are a little bit more, I hear patients who don't want to take a lot of medication since they're already taking so much. So just learning about the resources there, whether that's acupuncture, physical therapy, occupational therapy, resources like that. Psychiatrists as well. Sometimes the symptoms are so significant in their lives. It is something that I tell them to consider or recommend that. A big part too is nutrition. That's out of my wheelhouse. So I tell them, you can connect with the nutritionist. I put in those referrals for them so that there's more ease and less on their plate to have to do when they already have so many appointments and so many, life and day-to-day tasks that they have to do. Here at Facey, we have a nurse navigator. Sometimes patients really don't understand, like, what are these medical terms? What does this mean? And their oncologist has 15 minutes with them, so they don't really have that luxury to walk through everything. So we have our nurse navigator at the infusion center, and she supports them in kind of understanding and that they have informed decision making. Let's see. Yes, I also tell them that there are outside resources from here. Tap into the ones that they have, whether it's their faith community, which is important for many of my patients. And sometimes in their faith communities, there are cancer support groups. But even outside of that, I tell them there are ones in person and also virtually that they can connect with.
That's, I think, a great overview of the importance of this multidisciplinary approach and the importance of different care teams. And you briefly touch on this as well, but so in your experience, in terms of different formats that you find helpful, obviously every patient is different, but is there a specific one that you think helps the most to patients who especially have the challenges with pancreas cancer? Are those one-to-one sessions, or you think group therapy is more helpful, or are there online support communities?
Yes, it's very individual to people. So I tell them, check in with how you're feeling about one-on-one therapy or group therapy. Some people feel a lot more comfortable with one-on-one conversation. Whereas some people prefer to have that group setting, especially hearing other people who might be experiencing very similar things and they feel less alone. I have found it's a 50-50. Some people say they find that really helpful for that very reason, whereas other people tell me, I tried group therapy and it is not for me because it makes them feel worse. They tell me, they start to compare, like, oh, my diagnosis isn't that bad, or my treatment isn't that. And so it makes them feel like, oh, maybe I shouldn't be feeling as bad as I do. And I don't find that's helpful. So I tell them it's okay if group doesn't work for you and one-on-one is better. So again, it's very personal. And I do tell people to be mindful. Also, some groups are led by like a therapist or a doctor or a nurse. Others are more self-led by people who just have a spirit to support in this way or have gone through this experience. And so I do tell people to be mindful of what is the energy that they receive, what's the messaging that they receive, and if they ever feel uncomfortable or if there's any comparison that comes in, that it's okay to leave that and find somewhere else because there's a lot of good places.
Thank you. Thanks a lot, Namele. It was great having you with us today. Thank you again for your time and contribution.
Thank you very much.
Our next speaker will be Teresa Pace. Teresa Pace is a licensed clinical social worker with over 30 years of clinical and leadership experience in social work and healthcare. Currently serving as a medical social consultant for ambulatory services at UIC Health since 2023. Her career at UIC Health includes prior role as a hospice social worker, medical social consultant for outpatient and home dialysis programs, and the shared position with the epilepsy team in the neurology department. Teresa has worked across a wide range of settings, including hospitals, hospice, mental health units, child welfare agencies, senior services, and has held leadership roles serving in children, seniors, and special needs populations. She is deeply committed to community service, having served on the boards of the Future Foundation and Emory Face, and holds a Master of Social Work from the University of Michigan, with dual concentration in policy, planning, administration, and clinical practice. Teresa, thank you for joining us today. To start off, can you tell us a little bit about your role as a social worker in the hospital and the kind of support you provide to help families navigate these social determinants of health?
Absolutely, and thank you for having me. As a hospital social worker, my role is to support families and patients as they move through the healthcare system. And we address the social factors that can impact their recovery. In the inpatient setting, the focus is safe discharge planning. This means meeting with the patients and the families to discuss the post-acute options and working very closely with the medical team to set clear expectations and make the proper referrals that may be needed. This would include coordinating services such as home health, skilled nursing placement, transportation, substance abuse, psychiatric transfers, hospice palliative care, and services related to interpersonal violence or elder abuse and child abuse. In the outpatient setting, the relationship may be a little bit shorter term, but is still very focused on connecting patients to the right resources. And this includes mental health services, homemaker services, substance abuse, transportation options, and financial and food assistance, disability or legal guidance, the interpersonal violence resources, and housing support. And I will add that across both of these settings, we focus on social determinants of health, which play a significant role in a person's ability to manage their health. And our goal is to help patients and their families overcome and navigate these barriers so that they're able to engage in their care and promote stability and support their overall well-being.
I see. That looks like a comprehensive both inpatient and outpatient, support for these patients. And in regards to social determinants of health, one important component is obviously the food insecurity, especially in underserved communities. So how would you explain food insecurity and what kind of referrals or support you provide to patients facing it?
This is a great question. Thank you. Food insecurity means that a person or household does not have consistent or they have limited or uncertain access to enough nutritious food for an active, healthy life. Food insecurities can be influenced by many factors: limited income, job loss, high medical expenses, or the added burden of managing chronic illness. As a social worker, I encourage patients to talk to their providers. This may be doctors, nurses, social workers, nurse practitioners, patient navigators, so we can understand their needs and connect them with the appropriate resources. These resources may include local food pantries, community food programs, and hospital-based initiatives. For some patients with medical nutritional needs, such as a prescribed diet or supplements or medically tailored foods, we work very closely with our doctors and dietitians and the healthcare team to discuss meal planning. And in some cases, the insurances will cover some specialized nutrition foods like total parental nutrition, which is nutrition that a person only receives intravenously when they cannot use their digestive system, or any nutritional supplements like orally, like Ensure. And we will also coordinate home health and the medical equipment to receive these supplies accordingly. And again, our goal is to help the patient access stable and healthy food options to reduce the stress that food insecurity places on their overall health and their recovery.
Obviously, food insecurity is important, but there are also many other social determinants of health challenges. Could you share a story about a time you help a patient or a caregiver to work through one of these challenges?
Certainly. I often work with patients who are traveling several hours from downstate Illinois or out of state to receive the specialized care that is provided here at our campus. And when I tried to arrange we tried to arrange a transportation, the insurance's first question was why? Why are they coming from so far away? And asked whether they could see someone closer to home. Of course, this created delays and a lot of anxiety for the patient and their caregiver. But after speaking with the patient and the caregivers, I also learned that they had tried local providers, but couldn't access the specialty care that they needed. So I contacted the insurance company, explained the medical necessity, and we provided the documentation required to approve the trip. Once that was resolved, we coordinated the transportation to fit the patient's need and schedule. And I also helped the patient and caregiver understand what to expect going forward and how to request transportation without hopefully repeating the same barriers. So to me, this is a good reminder that sometimes one of the biggest barriers isn't always the medical, but logistical. And social workers are here to help patients and caregivers navigate these challenges so they can focus on their health.
I see. Yeah, that's great. And obviously, in addition to what we do and what all the support services and the inpatient, outpatient clinics do, there are also a lot of community partnerships and resources that are available outside of the hospital. Among these, is there a particular one that you have found to be really helpful for patients with complex needs?
Well, I cannot say there's just one. We rely on a wide network of community partners to support our patients with complex social and medical needs. For patients with cancer or other serious illnesses, what is very helpful are disease-specific organizations that are very especially valuable. These would include groups like the National Pancreatic Cancer Foundation, who also have a helpline where patients and families can call, and groups like the National Pancreas Foundation, the American Cancer Society, and some of our local providers like the Wellness House, Gilda's Club, and Immerman Angels offer support groups, education, exercise and nutrition programs, and counseling and peer mentoring. Patients can self-refer to these programs, but with their permission, social workers can also make referrals directly. We often highlight and remind them of these supports and that they understand, the patient and caregiver understand where to begin and what treatment options are available and what additional help they can access beyond the hospital. As you can imagine, a cancer diagnosis can bring emotional and practical challenges. It's normal to experience emotions such as sadness and fear and anxiety, depression, sleep changes, appetite loss, irritability, and temporary appearance changes in their skin and nails. And a big one is also hair loss. And difficulty managing just the daily activities of life or work. So these community organizations, they play a key role in helping patients and caregivers cope and feel connected. And as a social worker, our role is to bridge any gaps. So we listen to what the patient needs, we link them to the right services inside and outside of the hospital so they can never, they never have to navigate these challenges alone.
Well, that's great. Teresa, you were mentioning the gaps. One of these gaps also that is often encountered by patients is regarding mental health support. So how do social workers support mental health? Can you talk a bit about the different, types of mental health support that
Absolutely.
provide?
Yes, absolutely. We as social workers play a very important role in supporting our patients' mental and emotional well-being. One of the first steps is building trust. So I often will ask the providers I work with before you refer a patient to social work. It's helpful for you to explain to the patient why you're referring the patient and share what was discussed during the visit, including any cultural considerations, language needs, family dynamics, and patients can be connected to us through different ways, either giving them our phone number to call us directly, or the doctors entering social work consultations. And once we we get that referral, we meet with the patient, we help them understand the different types of mental health support. And these may include individual counseling for ongoing support, psychiatry for medication management, and support groups focused on general coping, chaplains who focus on spiritual support, pet therapy, and disease-specific issues like pain, grief, and adjustment to illness. We also assess for any safety concerns. If a patient expresses active suicidal or homicidal thoughts, we follow our agency's protocol and ensure that the patient is safe and not left alone. When needed, we may escort our patients to the emergency room for further evaluation. There are some tools that social workers use, like the patient health questionnaires, to identify or measure the depression that the patient may be expressing, and the Columbia Suicide Severity Rating Scale to screen for suicidal ideations and behavior. Beyond that, social workers can teach practical skills that help the patient manage their stress and feel more grounded. And this would be goal setting, coping plans, relaxation and breathing exercises, mindful strategies, grounding techniques, and problem solving. And when needed, we also refer the patients to cognitive behavioral therapy or other specialized mental health services. There are also many free mindfulness and guided meditation applications that patients find helpful, such as Calm or Headspace or Smiling Mind or Oxford's free mindfulness based programs. So ultimately, our goal is to meet the patients where they're at, provide emotional support, and help them access the level of care that best meets their needs, whether that's short-term counseling, support group, or long-term mental health care through insurance-approved providers and community partners, and we as social workers.
That is great. Appears to be a very comprehensive approach. Thanks for that insight, Teresa. In particular, when you are working with African American Black patients who have pancreatic diseases or conditions, are there social or environmental factors that are often overlooked?
One factor that we see frequently is medical distrust, shaped by historical experience or the personal encounter of the patient with the healthcare system. Many patients come in carrying this mistrust, and we as providers acknowledging it by using our trauma-informed approach to care can be an important first step in building that therapeutic relationship. Cultural identity is also plays a significant role, as patients may identify as African American, which is an American born in the US of African descent, or Black, which is an African descent, including those not born in the US, or Afro-Latino, a person of African descent living in or coming from a Latin American country. And there's also our Black, Indigenous people of color, each of these with their own unique cultural backgrounds and experiences. So recognizing and respecting these identities help us provide a more focused, individualized, and culturally responsive care. Language also, access is another critical consideration, as patients often are more comfortable and engaged when they can speak with clinicians or staff who share their language, their cultural background, or their gender identity. When possible, we work to honor those preferences to support effective communication and trust. Beyond these, we also consider economic stability of the patient. Are they currently employed? Do they have a source of income? Are they unemployed? How do they typically access health? What is their literacy level? Transportation access, their environmental safety, and the strengths of the patient's social support, or do they lack social support? All of these elements are significant and can significantly influence a patient's ability to engage in care. And to address these needs, we collaborate again closely with our community partners who provide education, support groups, and our culturally responsive services so that our patients will feel supported, understood, and represented throughout their care journey.
Thank you, Teresa. And lastly, are there any questions you usually get from patients or families that people might not otherwise expect during your interactions?
A common one, again, is around trust. Patients will often ask whether their concerns will be taken seriously or dismissed. The fear or mistrust is real, especially if they've had a previous negative experience with the healthcare provider. We are also frequently asked about the treatment paths. Some are discussed are radiation, chemotherapy, surgery, and whether they truly have to follow the recommendation plan. Some patients want to know the alternatives, and others may be thinking about stopping treatment altogether and pursuing palliative or hospice care. Social worker works very closely, myself, with the medical team to schedule meetings to talk with the patient and family as to what's clinically safe, what are the treatment options, and what matters most to the patient. And we will meet them where they are on this journey. We also let them know that the social worker is here as a steady support, and we do encourage them to try to join a support group or meet a mentor or connect with programs like Imerman Angels, which match patients with trained survivors. And when someone is newly diagnosed, we ask our providers, newly diagnosed with cancer, we ask our providers to please refer the patient to social work for extra support. And the social worker will connect with the patient as I do, and if and when needed, also bridge the gap to a community provider for ongoing support outside of the hospital setting.
Thank you, Teresa. Social workers are definitely an essential part of the care team, and we appreciate you highlighting how this important support can make a meaningful difference for our patients. And thank you so much for your time and contribution.
Thank you.
In today's webinar, we had the privilege of hearing from a social worker, a mental health specialist, and a nurse navigator. They discuss how their roles are to support patients and families, particularly those from minority communities, in overcoming social determinants of health challenges, with the goal of improving care experiences and health outcomes following a diagnosis. I hope this webinar will be a good resource for patients with pancreatic diseases. And if there are any questions, please feel free to reach out to National Pancreas Foundation. Thank you.